Let's get into it. We've got a highly structured syllabus today. We'll start with safety and core objectives, then move on to the supine position and its modifications. After that, we'll tackle prone position mechanics, lateral position protocols, and finally, we'll wrap up by looking at complex pelvic alignments in the lithotomy and Lloyd-Davies positions.
All right, Section 1, Safety and Core Objectives. This is all about establishing the baseline.
Now, proper positioning isn't just about, plopping a patient onto the table. It actually starts with really strict pre-planning before the patient even enters the room. Our core objectives here are to facilitate safe anesthesia and surgery, reduce adverse physiological insults, optimize surgical exposure, which is obviously key, and vitally, maintain patient dignity by avoiding any unnecessary exposure. So to pull this off, we need a flawless pre-positioning plan. We have to run final checks on the table and all its accessories. We need to make sure the laparoscopic stacks, electrosurgical units, and nursing trolleys are perfectly set up. We've got to double-check the placement of passive diathermy leads and underbody heating blankets. And, absolutely crucial here, we must consider the individual patient. What's their age, their body habitus, their joint mobility? Every single one of these factors completely dictates how we approach the transfer.
So all of this meticulous pre-planning builds right up to the physical transfer itself. And let's be clear, this is a critical, high-risk moment. The risk for patient falls, injuries, or even physical injury to the theater staff is incredibly high right now. So how do we mitigate that? Through really strict coordination. Step 1. The anesthesiast managing the airway is the boss here. They coordinate the transfer by calling the count. Step 2. The transfer is always executed as a shared team movement. And step 3, if we're dealing with obese patients, emaciated patients, or folks at the extremes of age, we have to utilize specialized patient care and transfer equipment. You simply cannot rush this process.
So the crucial point we need to understand is this concept right here, the physiological compromise. If you only take one core philosophy away from this explainer, let it be this one. A clinical compromise absolutely must be reached between achieving perfect surgical exposure for the surgeon and maintaining a physiologically permissible position for the patient. Basically, every tilt, every rotation, and every tuck comes with a physiological cost, and we constantly have to weigh that cost against the surgical need.
Moving on to Section 2, the supine position and modifications, our baseline posture.
As you probably know, the supine position is the most common baseline for general surgical procedures. Usually, the arms are tucked safely by the side or extended on arm boards for IV or arterial access. But surgery rarely stays entirely flat, right? For head and neck surgery, we use Rose's position, which involves a slight neck extension. If we're doing axillary and breast surgeries, the shoulder and arm are extended to give us that necessary access. But what's really fascinating here are the exaggerated intraoperative changes we need for advanced laparoscopic surgery, like, say, a rectal resection. In these procedures, we need frequent, steep position changes to literally let gravity shift the organs out of our way. So, tilting the patient to the right mobilizes the left colon, while we might use super steep angles for deep pelvic dissection.
Now, the most famous of these tilts are the Trendelenburg and reverse Trendelenburg positions. In the standard Trendelenburg, which, fun fact, was first described way back in 1885 by Friedrich Trendelenburg, the head end of the table is tilted down on an incline and the patient's knees are slightly flexed. This is huge for pelvic procedures, and it's also a go-to when resuscitating a patient in shock. The reverse Trendelenburg is, well, exactly what it sounds like. The head end of the table is tilted up, putting the head higher than the feet. We often use this to let gravity pull organs, like the transverse colon, downwards and out of the surgical field.
But here's the catch. Gravity works against us too. When you tilt the table like that, securing devices become absolutely vital to keep the patient from sliding. The safety belt is totally standard, but we have a hard and fast rule here. It must be placed exactly 5 centimeters above the knee, and it is never ever placed over the abdomen. Shoulder supports are mandatory to secure patients in steep Trendelenburg, while foot supports stop them from sliding right off in reverse Trendelenburg. Side supports prevent lateral displacement if we're doing sideways tilts. And actually, we also use vacuum-activated systems now, which are these fantastic alternatives that gently conform to the patient's body contours to secure them safely and comfortably.
Now, even in the straightforward supine position, things can definitely go wrong if we aren't highly vigilant. We're talking potential complications like pressure necrosis on the heels, shoulder, sacral region, and even the scalp. In steep Trendelenburg, patients can actually suffer respiratory compromise, as well as elevated intracranial and intraocular pressures. But let's zero in on nerve damage for a second, specifically neuropraxia of the ulnar, axillary, perineal, and brachial nerves. To avoid brachial plexus injury, the arm must never be abducted past 90 degrees, period, no exceptions. Furthermore,
Pronation of an extended arm causes incredibly dangerous traction on the brachial plexus and puts direct damaging pressure right on the ulnar nerve. Precision here is non-negotiable.
All right, let's shift to Section 3, Prone Position Mechanics, the posterior approach.
The prone position, meaning face down, is primarily used for spinal surgery and extralevator abdominoperineal excisions for rectal cancer. And let me tell you, it is highly complex to execute safely. Step 1. The patient is intubated first. This absolutely has to happen while they are still on their back on the transport bed. Step 2. A minimum of 4 team members perform a very careful log roll maneuver to turn the patient face down onto the operating bed. Step 3. Depending on the surgery, we might apply the jackknife modification, which literally bends the table to give us excellent clear access to the perineum.
Once they're prone, the work isn't done. We have to meticulously verify every anatomical region from head to toe. For the head and face, we use specialized hollow pillows. These accommodate the endotracheal tube while safely supporting the forehead and chin. For the chest and torso, axillary and lateral chest rolls are essential. Without them, the patient literally cannot expand their chest or use their diaphragm to breathe. We also have to ensure the careful physical positioning of female breasts and male genitalia to prevent any awful crush injuries. The arms are usually placed up by the side of the head using reversed arm boards, and that requires extreme care to avoid dislocating the shoulder. Finally, moving down to the feet, pads have to be placed under the shins to make sure the toes are elevated entirely off the bed.
The complications we face in the prone position are honestly quite severe. We're looking at risks like brachial plexus injury, shoulder dislocation, and pressure necrosis on the breasts, external genitalia, and any bony prominences. There's also the terrifying risk of accidentally displacing the endotracheal tube underneath the patient where you can't easily reach it. But perhaps the most alarming specific risk here is facial trauma, which can include actual blindness secondary to vascular congestion of the eye. Proper support and frequent obsessive checks are really the only way to prevent this.
Moving right along to Section 4, Lateral Position Protocols, Side-Lying Access.
We often use left or right lateral positioning as a really useful alternative to the prone position for things like draining perianal or pilonidal abscesses or accessing the thorax during a lateral thoracotomy. But there is a very specific variation here called the kidney position. This is a modified lateral posture achieved by literally breaking or angulating the operating table right at its summit. By bending the table like this, we physically widen the space between the patient's costal margin and their iliac bone. It dramatically aids urological and retroperitoneal access. It's a really clever table maneuver.
Now, when executing this, there are very strict alignment rules required to keep the patient safe on their side, and this brilliantly illustrates how we stabilize the body. The lower leg is slightly flexed at the knee, just to give a solid base of stability. A pillow is placed between both legs to relieve pressure, and then the upper leg is flexed in a more exaggerated position. The arms are usually safely placed in arm stirrups. And throughout all of this setup, maintaining strict cervical alignment of the head is vital, so the spine remains totally neutral. But, as you might guess, the side-lying position introduces some unique physiological challenges. Respiratory complications are super common here. We see preferential ventilation of one lung over the other simply due to gravity and compression. We also have to worry about accidental endobronchial tube migration. Neurologically, we're watching out for traction injuries to the brachial plexus as well as ulnar nerve injury, and we also have to diligently protect the eyes because lateral positioning significantly increases the risk of corneal abrasions and ocular trauma just from the head resting sideways on the pillow.
And that brings us to our final section, lithotomy and Lloyd-Davies. Complex pelvic alignments.
These setups are the primary choices for gynecological, perineal, and urological procedures. The patient is supine, legs flexed at the hip and knee, and secured in stirrups. However, there's a really distinct difference between the two configurations that gets confused all the time. In a true lithotomy configuration, the hips are flexed to a full 90 degrees, even though the exact knee flexion can be adjusted. The Lloyd-Davies configuration, on the other hand, is a specific modification. Here, the hips are only minimally flexed, usually to about 15 degrees, and then this is combined with a steep 30-degree head-down Trendelenburg tilt.
So, let's walk through the strict rules for lithotomy positioning. Step 1. Both legs must be lifted and placed into the stirrups simultaneously to avoid wrenching the pelvic strain.
Step 2, and this is a massive safety hazard warning here, fingers must absolutely not extend past the edge of the table breaks. If the bottom section of the table is dropped while a patient's hand is resting there, fingers can be crushed or even accidentally amputated. It is a terrifying thought. Step 3, the legs should not be externally rotated or unduly abducted. And Step 4, because these cases can be pretty long, sequential compression devices are highly recommended to prevent venous stasis.
The big thing to remember with lithotomy is that the risks are deeply tied to how long the procedure takes. In the vascular category, long procedures can lead to venous and arterial insufficiency. That causes limb ischemia, compartment syndrome, and massively increases the risk of deep vein thrombosis, or DVT. Neurologically, hyperflexion can cause severe sciatic nerve damage. Also, the hard edges of the stirrups can cause saphenous or peroneal neuropraxia just from direct pressure. And as we literally just mentioned, traumatic injury like digital amputation at the table breaks remains a rare but completely preventable catastrophe.
Wow, we've covered a tremendous amount of ground today, exploring the exact mechanics and severe risks associated with every tilt, tuck, and turn on the operating table. But it all comes right back to the core philosophy we started with. So, I want to leave you with this final thought to consider. Have you fully accounted for the physiological compromise before initiating your next surgical patient transfer? Remember, perfect surgical exposure means absolutely nothing if the physiological cost to your patient is too high. Thanks so much for joining me on this explainer, and be sure to keep these checks at the forefront of your practice.